Thank you. Good afternoon and welcome to West Berkshire Health Scrutiny Committee. I am Councillor Martha Vickers, Chairman of the committee. Members of the committee present this afternoon are Councillors Jane Langford, Nick Carter, Justin Pemberton and Owen Jeffrey. Councillor Caroline Culver is also present as Chair of the Healthcare and New Developments Task and Finish Group. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Executive Director, People, Adult Services, Anne-Marie Dodds. No, Anne-Marie Dodds can't be with us today. April Pebbody, here in person, Acting Service Director, Communities and Wellbeing. Kate Toon, Project Manager, Integration and Quality, Adult Social Care. Charlotte Pavitt, Consultant in Public Health. John Ashton, Director for Public Health. Helen Clark, she is here today. Yeah, Helen Clark, Deputy Place Director, Berkshire West, Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. Peter Hunt, LTC Implementation Manager for Single Places, Berkshire West. And Kiera Walker, Integrated Diabetes Delivery Network Manager. Vicky Phoenix is the clerk for the meeting. The meeting is also being live streamed via YouTube and Gordon Oliver is the Zoom host. Before we start proceedings, I would like to explain for the benefit of members of the public who may be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. Please can I ask everybody present in the meeting to make sure they switch on their microphones when invited to speak directly into them, and then switch them off when finished speaking. If we hear the fire alarm this afternoon, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted before we proceed? No. Right, item 1, apologies. Vicky, do we have any apologies?
Yes, Chairman, we've received apologies from Councillor Heather Codling, Chair of the Health and Wellbeing Board.
Thank you. The minutes, hopefully members have had a look over the minutes of the meeting. First of all, we have 2 sets of minutes. First of all, the meeting held on the 12th of March, 2024. Can I have a proposer for those minutes, please? Thank you, Councillor Jeffrey. And a seconder. Thank you, Councillor Pemberton. All those in favour? That's everybody. Thank you very much. And then we also have the minutes of the meeting in May, which is a very short meeting. Can I have a proposer for those? Thank you, Councillor Jeffrey. A seconder. Thank you, Councillor Carter. All those in favour? Thank you very much. Now I have to sign those.
Can you pause the meeting for 1 moment? And God is just going to change over the Zoom call.
Right, apologies, we need to pause the meeting for some technical. Right, hello again. I believe we had some technical problems at the beginning. So for those who missed the what went before, welcome. Welcome Helen and Charlotte, I believe you're out there, and anybody else. We are just up to item 3. All we've done so far is just go through who's attending and approved our minutes. So we're now up to item 3. Where members are asked to note the progress in relation to the actions coming out of the minutes of the previous meeting. Any comments from members about the actions? Councillor Carter, you had an action in there. Is that okay with you? Councillor Carter? Yeah.
Sorry, could you just clarify which one you're talking about?
I think there was an action in there relating to pharmacy provision.
Yes, there was an action on the lady rather than on me. Yeah, so I haven't heard the. I think yes, it's correct in terms of the minute. Yes. Was that the question?
Just asking if you had any comments on that.
I've heard no progress on it, although Vicky's advised me that it's being worked on. I haven't heard the outcome of it. Thank you.
All right. Thank you very much for that. Thank you. And there's a note there that we'll be hearing again from early years inequalities next year. Hopefully we'll have an update on the specific 3 to 6 month contract that was mentioned before then. That will be before then. And by digital, we mean did we express concern about the fact that that was digital, or whether it was happening because digital obviously means there's no face-to-face contact?
But it's probably cheeky of me to speak with Nick being here, but if you recollect, it was this business that the pharmacy couldn't actually process the digital prescriptions, and that seemed to be utterly ridiculous, and people were walking from the pharmacy to et cetera, et cetera, et cetera, et cetera. And that was the issue that was going to be taken up. I must admit, I would have thought that in 3 months that could have probably been put to bed one way or the other. I am mildly surprised.
Why it's marked in progress?
Yeah.
Do we have?
There was a confusion at the Integrated Care Board on one of the questions, so we're just going back to finalise it, and it shouldn't be too much longer.
Okay, thank you for that. Yeah, I think it's important that we do deal with that as quickly as possible, because it must be causing a lot of inconvenience to people.
Yeah, yes. Sorry, yes, absolutely. So I'm expecting the answer to be how that process is going to be changed. That's the answer I'm looking for. Because as discussed in the last meeting, yes, the fact that, as Councillor Jeffries says, the member of the remote pharmacy is walking backwards and forwards to collect prescriptions on a daily basis, which apparently is not specific to Mortimer. I thought it must be, surely, but apparently in the last meeting it was explained that it's not the only place it happens. So that was the point, that we're looking for an answer, a confirmation of that process being fixed. Yeah, thank you.
Okay, thank you for that reminder, and it is an important issue, so let's hope it progresses quite soon. I think we have Helen Clark with us, and she wishes back to comment.
No, I don't wish to comment. It was only to say, Vicky, that if you need any help in contacting the right people within the ICB, it sounds as though you've got it in hand, but do let me know if you need me to follow anything up. Thank you.
Did everybody hear that? I didn't think the sound quality was very good.
No.
I don't know whether, is that our fault or is that? I couldn't hear it very clearly.
Any problems?
Sorry, can you hear me now?
It's a bit better. Yes, thank you, Helen.
Okay, it was only to offer help if Vicky needs any help in directing the query, although it sounds as though she has it in hand anyway. Thank you.
Okay, thank you for that, Helen. I mean, the quality of your sound is still a little bit not perfect. So maybe, I don't know whether it's a distance from the microphone, but anyway, thank you for those comments. Thank you. And I had mentioned the early years and the digital update.
Just to confirm, that was for clarity around what that digital offer was, and Neris needed to go back to the Commissioner for some information. So again, I've chased it and it should be with us shortly.
So that should be with us quite soon. We don't have to wait until the next meeting for that. Right. So item 4, any declarations of interest from members? No. Item 5, have we received any petitions, Vicky?
No petitions have been received, Chairman.
Thank you. Right, item 6, we have Councillor Caroline Culver with us, who is going to present the final report from the Healthcare New Developments Task Group, which describes the work undertaken and presents final recommendations. And can I just say, for those of us that took part in this, that's myself, Councillor Jeffrey and Councillor Langford, I think it was a really interesting task group and I think very valuable. So I think we were lucky to be part of that, because I thought it was quite enjoyable, apart from being interesting, wasn't it? So thank you, Caroline. And if you'd like to summarise the, thank you.
Great, thank you very much indeed, Councillor Vickers. Yes, so I will summarise this. I'll probably spend about 5 minutes talking through some of the key findings and then be very happy to answer your questions. Although I'm conscious that 3 members present were actually on the task and finish group as well, so we'll know much of this already. I'd particularly like to thank the officers that were involved in this, Vicky Phoenix and Elizabeth Gowans, and also Laura Callan and Bob Dray from planning. All 4 of them made invaluable contributions to our discussions. I'd like to also thank Councillor Nigel Foote, who isn't with us today, but was also a member and made invaluable contributions to our discussions also. And also I'd like to thank members of the Integrated Care Board, in particular Peter Redman and Helen Clark and Jeffrey Ung, who came along to our meetings and really did have some extremely interesting things to talk to us about. And finally, Dr. Heike Veltman from Thatcham Medical Centre and Dr. Andrew Baroni from Savills, who also gave evidence. The recommendations support the core business activity of the council, and they also support the council's strategic priorities. I would like to say it was very much a privilege to chair this group on behalf of Health Scrutiny Committee. I found it extremely interesting, and I've learned a lot more as a result of what we discussed. We basically looked at 2 different elements, adequate healthcare in areas of increasing population, and design of new developments to promote health and well-being. And we had 3 elements to our scope. We did have terms of reference which actually expanded during the course of the discussions because it began in the previous administration, and then we had a little bit of a rethink about how we wanted to take it forward. And I think that extra time was invaluable because I think what we've come up with has been much better as a result. So the 3 elements, part 1 was assessment of health needs in new developments. Part 2 was health in planning policy and planning consultations. And part 3 was funding and delivery of primary care and public healthcare services in new developments. Some of the things that we discovered, which I will highlight, new developments need to have at least 4,000 houses to warrant having a new standalone health centre, which was quite interesting and surprising to us. That's obviously a very big number and a lot bigger than many of our major planning applications. We also looked at all of the challenges that face GP practices. So their own demographics, for example, if they're near to retirement, they might not want to lease a new building, or they might have a mortgage arrangement where there may be a negative equity. So for that reason, they might not want to move to a different site. They have difficulties with transport. So we've got rural hubs for GPs in this district, for example, and that means that the people who work in those areas don't necessarily feel as supported as those who are in major health centres. We talked about the need to have hubs where we can have more specialists. So it's not just a GP, you can have social prescribing, you can go to the pharmacy, you can go to see other specialist practitioners as well. We also looked at issues around community infrastructure levy and Section 106 agreements, and we discussed the challenges that if a developer doesn't get Section 106 monies, if we don't get those monies straight away, we can't necessarily build a new doctor's surgery anyway, and it may be one of the last things that's built on a new development. And that puts extra strain on the GP surgery. So we talked about SIL, we talked about Section 106. We also talked about the healthy planning protocol and the health impact assessments. That was a big part of our deliberations, and that was extremely interesting. It's very clear that our professionals here who are working on healthcare and on planning are already talking to each other a great deal about how we make sure that developers have consideration for healthcare basically when they're designing new developments, and that they talk to our planning officers very early in that discussion, basically before the pre-application, so that they're really, really thinking about healthcare. Some of the positive things that are coming out of it: the Integrated Care Board will now be a consultee if there is a development of 10 dwellings or more, which was not the case before. So we talked about some examples of where the Integrated Care Board has not commented on a planning application until it is too late in the day. So, for example, in my ward in Compton, they commented when we were discharging planning conditions. So it was way past the point of making a useful contribution because the Section 106 had already been agreed. So the fact that the planners and the ICB are now talking to each other well in advance of those major applications going in, I think is very, very positive. They are also talking about SIL and how they can change that in the future, because that's reviewed periodically. We heard about how in South Oxfordshire, 20% of SIL money goes to healthcare and healthcare infrastructure. But in this district, we have 10%, which is allocated to other services, of which health is one. So it is clear that there are lessons to be learnt from other local authorities about the way they distribute their SIL monies for healthcare. So there's much to be learned from that. And we also talked about design in the longer term. We do have policy DM3 in the local plan, which will give more weight to healthcare on new developments. So that's obviously a very positive development there. So last but not least, to conclude the points, we have 6 recommendations. Just scrolling down. So recommendation 1 is around planning and health to continue to improve collaboration on planning consultations and in developing flexible ways of working together. As I said, the planning officers and health officers here are working very closely with the ICB. So that's very positive. New opportunities in funding and delivery of primary care in the community. So that's where we talked about the SIL and the Section 106, and there are recommendations there. We talked about the healthy planning protocol, the fact that we would like to embed that in our planning system. We would like developers to complete a health impact assessment when they submit their planning application. We want to make sure, obviously, that we have enough capacity in the planning team to look at those assessments and to make sure that anything that is agreed in a planning application is enforced as well. So we would like to see an additional new officer post. And scrolling down, wider approach to healthy places. So this is in relation to design and having design guides for the future, which we would like to look at in more detail. So those basically summarise the key points that we discussed. I hope that the recommendations are clear and that the Health Scrutiny Committee is happy to propose that they go up to executive for their consideration. And it's also recommended, Chairman, that they go to the ICB also for any further comments that they might have to make on this. Again, I thank the officers, I thank the members for their contribution, and I hope that this has been a useful task and it will reap benefits for the people of this district in the future. Thank you very much.
Thank you very much, Caroline, for that summary, which is very useful, especially for those who weren't on the task group. And I'd like to also second the thanks for Vicky, who did an excellent and very clear and thorough report, which hopefully, again, for those who went on the committee, would have found useful. Yeah, I thought it was excellent. I mean, the things that stood out for me was an understanding of the GP's dilemma, and also how they could be assisted and how the provision locally has got to change in future. And also the discussion we had about how it's not just about GP practices, it's not just about the buildings, it's about the whole thing, the sort of open spaces, the facilities, April's nodding with a public health hat on here, facilities for people to have good quality of life. And I think in the report somewhere it says only 10% of population's health and well-being issues are related to healthcare. So, you know, it's really about where you live. It's about your housing and it's about your green spaces. And I was just going to add here, because I think it's interesting. I went to a conference organised by Babout in Reading about a month or so ago. I think the invite was possibly sent to all members. I'm not sure, or maybe it was just for Babout people. But it was fascinating because I think we all think about Babout as you're championing wildlife, which they do, and not so much sort of welcoming people onto reserves and things. But this was about the benefits of wildlife and green spaces to us, really. And there were some excellent presentations, one from the chap who started Healthy Walks, possibly out Reading Way, and how the brain of children who are brought up around green spaces actually is quite different. The brains develop differently from those who are not. I can't remember all the technical terms, but I thought that just shows there is real scientific proof about the benefits of green spaces. So I just thought the whole thing was fascinating. Members, any comments or questions or things you want to highlight? Councillor Carter.
Yeah, thanks very much. Yes, I wasn't on the group, so hence there's a danger that, yes, because I joined this team in post 2023, so therefore potential stupid questions coming here. In no particular order, you mentioned it's really a question to Councillor Culver, if that's okay. You mentioned that planning were working closely with health already, which I don't doubt. But obviously the paper is recommending that they work more closely. Do the folks in the council agree with the wording of that first recommendation?
Who agrees, sorry?
The planning, sorry. Because it's kind of saying we need to work more closely, but you then also said, I thought in your talk that they work working closely with the ICB. So I'm just saying, is everybody behind that recommendation within the council? So do the planning team think there is effectively improvement needed?
Through you, Chair. Thank you, Councillor, for your question. Yes, the officers from planning were key to this group throughout. They came to all of the meetings. So Laura, the policy officer, and Bob Dray, development control manager. And they had already been in discussion with the integrated care board about what we do going forward. And they are very, very mindful of the fact that they need to do more of that in the future. So in the past, there have been instances where the various NHS boards, so you had the CCG before, have not necessarily commented on major planning applications. And then they haven't had an input into the Section 106 agreement, for example, and then it's too late. So the officers here and the various generations of organisations within the NHS have been very conscious of the need to try and get their ducks in a row better about that. And this task and finish group was an opportunity for them to focus on those issues and how they make sure that they deliberate much earlier in the process. So I can reassure you the planning officers here are very on side with that. And as I mentioned, we have something in the new local plan as well, which will give greater weight to healthcare on new developments as well.
Okay.
Yeah, thank you.
Thanks a lot. Yeah, can I just ask there's a couple more? Thank you very much. Second one was when was before as regards the ICB not being a statutory consultee? Presumably you mean before the task group got its teeth stuck in the last year or two, I guess.
I'm not sure exactly when they decided it was going to be for 10 dwellings or more. So that's a relatively new thing as far as I'm aware. I know, for example, with Compton, with the Institute, that got planning permission in February 2022, and the NHS did not comment on it at that point. It only commented when the planning conditions were discharged, and then it was too late, basically. So since then, at some point, they have changed the rules and they've decided that they are a consultee for 10 dwellings or more. Yeah, which I think is very sensible, because otherwise a lot of developments would just slip through the net, and then you could have more and more houses being built without any due consideration to GP surgeries and other healthcare provision.
Yes, exactly. It's very interesting. It's very relevant. I hate to quote specific examples, but there is one. In Mortimer, we did a neighbourhood plan in 2017. There was a feeling in the village that it would be nice if the doctor's surgery relocated, because it's parking's tight, they're absolutely maxed out in there, and space was allocated to relocate it. But what's said in the report completely explains why the GPs can't fund moving it, because they won't get any more rent from the ICB under the model, and they're not in a position. I don't know the exact financial arrangement in the building they're in, but they can't do it. And by the way, there's only 110 more houses, which is not enough to need another doctor, need a bigger surgery. So all that's in here is explaining that very, very eloquently. I guess my final question was on couldn't help notice the recruiting another person for the task. And I guess just mindful of the fact that we're strapped for cash, let's put it that way. And looking at the activities that are listed there, which seem to vary from quite strategic to quite tactical, maintaining, not documents, but could it be done without hiring another member of staff? It's probably not a question for today. That's just a standard question. It's not, I'm not picking on this. It's some, if I don't ask, somebody else will. So yeah, that was the final one. Thank you.
Thank you, through you, Chair. Thank you, Councillor, for your question. Yes, my understanding is we are unfortunately going to be losing our programme officer for wider determinants of health, who played a big role in this task and finish. And then the extra staff member who we would like to have to make sure that the healthy planning protocol and the health impact assessments can be introduced properly and have somebody to oversee that process. Obviously this has to go to executive, so it will be up to executive. Well, you have to decide if you want to send it to executive. But if you do, and they would then have to decide whether or not they think they have the resources to employ this person. So it's very much a recommendation, and it's up to executive. But the issues that you outlined, it's very true. There are so many issues. Do they have a lease already? Are the doctors there due to retire, so they might not want to take on a new lease? We also learned from the ICB that they cannot hold any assets or capital, which makes the problem really difficult as well. So one thing I didn't mention, we talked about whether the council in the future could get involved in the development of these centres and maybe own them or part own them, because of the difficulties of who actually owns the centres, because the ICB can't. In an ideal world, I think the ICB would, and they could oversee it all, but that isn't the case, unfortunately.
Thank you.
Thank you for those questions, Councillor Carter. That sort of, brings it into focus. The experiences of your community are quite valuable. And yes, it's quite interesting that the community itself was telling the doctors what they wanted, and that's good. That should be the way it is. One issue I was going to mention, again, is probably, down to resources, was we also mentioned the need for training, public health, understanding of public health for all the councillors, and also training, particularly for the planning committee in the healthy planning protocol. And again, that is a resource issue, but I think that's quite an important one, because, if this is going to go to exec and it's up to the council to decide, we want them to have an understanding of the importance of these issues, which, in public health is still a bit sort of a nebulous thing to a lot of people. So will we confident we'll move forward with that, do you think?
Yes, training is one recommendation that we made in there. So for the planning officers, so that when they deal with the healthy impact assessments, they can actually assess them and they know what to look for. And obviously they'll need to know what they need to then enforce as well once a new development has been given approval. If they promise they're going to provide a new facility, that obviously needs to be enforced also. We also talked about having a session for members as well to make them aware of the new policy in the local plan and the healthy planning protocol, what it meant, how it would be implemented, etc. And we also said it would be good if ward members are consulted about these issues as well, because part of the healthy planning protocol, we will have a lot of data for individual wards about healthcare statistics there. And we were very keen that members are consulted, because obviously they understand their areas more than anybody does, and to make sure that their input goes into those protocols and assessments as well. Yeah.
Thank you for that. Yes, that's an important issue, making the use of our members. Thank you. Have members got any other questions they want? Oh, Councillor Pemberton, yes.
Yes, thank you, Chair. So first of all, thank you for the report. I really enjoyed reading it. It was long. Clearly a lot of work's gone into it. It's possible that I've missed it, so I'd be grateful if you could just give a bit of context around conversations on Section 106 payments, when developers would be liable to pay those, how much flexibility there is in planning terms, in terms of when those payments are made and how they can be enforced, because it's really important. It's mentioned in the report. It's all very well waiting till the end of the development, but if it's built out by then it's, in the meantime, you've got residents waiting for those really, really crucial services. So if you could just give us an idea of what the thinking around that was, and what that might look like in practice, that'd be really helpful. Thank you.
Thank you, Councillor. So yeah, as I mentioned, one of the things we looked at was the fact that other councils often spend more of their SIL monies on health, for example. So we want to learn the lessons of that and make sure that we are putting enough money into health. There's a lot of confusion around the difference between Section 106 and SIL monies as well, which we talked about. One of the things that we acknowledged was the fact that often the Section 106 monies are not forthcoming completely at the start of the process. So we can't build a new facility, for example, before the homes are occupied. Often many of the homes are already occupied before the Section 106 monies come through and something like a doctor's surgery can be built. But we did discuss the fact that it would actually be good from a developer's point of view if they started to provide those community facilities before the entire development is built out, because it's actually an incentive and might actually increase the value of the houses on that estate. If people come along and they can see that there are already community centres, health centres, etc. on that site, they might be more inclined to buy a house there. So we got a lot of insight from Savills, one of the developers who came along, which was very useful. And he made points like this, you know, from a developer's point of view, they really ought to think about the benefit of bringing that funding forward and putting those things on the sites as early as possible. So that discussion was part of what we looked at. I hope that's useful.
Thank you for that, Councillor Pemberton. Yeah, I mean, the issue of starting the discussions early was a very important one, even though the money might not be there. At least you've had the discussion and you know what's coming down the line, so you can start planning. So yeah, that's a very important point. So thank you for that. Yes, Councillor Carter.
Sorry, could I just chuck in another one that's related to what Councillor Pemberton said, actually? I think it came up on the local plan review. Maybe one of the things with SIL is that it doesn't necessarily provide enough to do these facilities, and that probably applies to the schools and the doctor's surgeries. You seem to, because that was one of the messages actually in our village. We were slightly sold the fact that if you have a neighbourhood plan, you get more SIL because we get a higher we get a higher contribution having a neighbourhood plan. And then if you want a new school and the doctors, and that was kind of why in our case, we put in a piece of land for a new school and a new doctors. We then found that neither for the reason given as per the report, the doctors can't fund the new doctors because there's not enough new houses. And even if enough is all relative, but in our case we're saying 110 homes in a population of about 4,000. Don't know how many homes we've got, so it's a reasonable amount, but it's nothing like enough to, if we spent all the SIL, it wouldn't go anywhere near putting a new building in. And I think that's a relatively common issue with planning, from my understanding.
I think if the committee agreed to send this up to executive, it's worth them having a think about whether they could give more SIL monies to health in the future. South Oxfordshire are giving 20%, and 10% of ours goes to what we call other services, and health is just one of those. So it's clear that we are dedicating a lot less of our SIL money to health than our neighbouring council in South Oxfordshire is. And that may well be the case compared with other councils as well. So I think that's something that the executive could have a look at and think if they could reconsider. I mean, what is quite interesting, the Eastfield House surgery, I noticed there was an article in the paper about this last week, and I believe it's the Greenham Trust who are the applicant. So that is an example of how a third party has come in and is going to make this possible. So it's not just, a smaller housing developer or the council or the ICB, it's actually taking somebody like the Greenham Trust to come in and be the applicant for this, that's going to probably push this over the line. So this is quite an interesting example, I think, in the context of what we've been talking about today. I think it is going to need a lot of stakeholders coming together in the future to try and make these bigger health centres possible and viable. Yeah.
Yeah, very wide-ranging report and very interesting. So, do members have any more issues before we've? Yes, Councillor Clement.
Hopefully the last question, we'll see. One of the practical implications of the report is that this will require another officer. It's just worth raising the point because obviously councils are financially stretched at the moment. I couldn't see any information within the report about the pay grade and banding and the cost. I'm not saying it's not worth the cost, but I couldn't see it, and I was just wondering if there's any information that you can share with us here today or not.
I don't have any information about the banding. No, that would probably need to be referred to a senior officer for more information. It may well be the case that officers have already been discussing that, but I don't have that information personally, no. I would respectfully point out to everybody, though, we have created some very, very senior roles in the council recently. I think these more junior roles are absolutely essential if we're going to get this stuff delivered. So if we're going to implement that policy in the new local plan, if we're going to introduce the planning protocol and the various assessments, we do need those staff that are doing that daily grind of work basically to get that stuff done. And it's going to be absolutely essential. One of the key things that we learned from this is the need for prevention in healthcare. And the work that this officer would do would make a great contribution to helping to prevent ill health in the future by making sure that those new developments are designed correctly. Yeah, thank you.
Right, well, thank you. And thank you for all those questions, which sort of really brought the report to life. We have to note here that, and it's relevant to what Councillor Pemberton has just said, that the recommendations haven't been assessed in terms of their budgetary and resource implications. And this is where they're being referred to the executive and to Bob ICB for their response. And there they will come back in due course to health scrutiny for confirmation. And obviously we can see what the final result of this working group was. So thank you very much, Councillor Culver, for your contribution. Thank you for the discussion. And do we have a proposal here to accept the recommendations? Or do we did propose or we just vote?
Yeah.
Proposer, please. Yeah, Councillor Langford. Yes, thank you. And Councillor Jeffrey, seconder. All in favour? Thank you very much. And thank you very much again for your report. And Councillor Culver has to leave us now. So anyway, thank you very much. Thank you. Right, well, we move on to item 7. Do we have John Ashton and Charlotte Pavitt here? We've got Charlotte here. Ah, there she is on screen. So we have Charlotte Pavitt, consultant in public health, to present the report by herself and John Ashton, Director of Public Health, which you'll have had in your papers, a very full and a very interesting report about the history of public health. It was it was really quite interesting to read, and there is also going to be a presentation to highlight the main points of the report by Charlotte, and then it's open for members' questions. So over to Charlotte. Thank you very much.
Thank you, Chair. Thank you all for having us. So yes, I'm going to run through a couple of the slides. It's a condensed presentation of the full slide deck that you should have all received as well. And just to sort of give a bit of a background to the annual public health report, this is something that is completed annually by the Director of Public Health. It's an independent report, and we bring it here today for information, for discussion. The report will be going to the Corporate Board and also the Health and Wellbeing Board ahead of public publication. So let me share my screen with you. Okay, unfortunately it's saying that the screen sharing has been disabled.
Try again.
That's great, thank you. And I hope everybody's able to see the full screen of the presentation. Please do let me know if that's not the case.
It's not taking up the whole of our screen. I don't know whether is that our problem or yours. We can't. It's quite small, actually. The presentation on the screen.
Try again for you. Okay. Hopefully that's
fine. Thank you very much.
Fantastic. Okay, so this is this year's 2024 annual public health report, and it's the first annual public health report that's had the focus on West Berkshire as a local authority. Previous reports have always had a wider geographical footprint, with the Director of Public Health covering a number of the local authorities across Berkshire, either Berkshire West rather, or Berkshire as a whole. So I just wanted to refresh the content and the approach that we've taken for this report. it goes through the history, and we learn from the history, as Chair has kindly highlighted, in order to give us some direction moving forward. It looks at that public health vision for West Berkshire moving forward, and where we currently are in relation to health protection, health improvement, and healthcare public health, what we've achieved over the past 12 months and previously, and therefore what the priorities might be moving forward, before concluding and giving some overarching priorities. And today I just wanted to focus a little bit on that context setting and the history, a little bit around where we currently are in relation to health protection, health improvement, and then those overarching conclusions. So not going into too much detail for each of the three areas, but more than happy to take questions and have discussions around that. So there's been some fantastic achievements to date noted throughout the report, and particularly, as was previously discussed actually in the previous agenda item, around the Health in All Policies work programme that's certainly evolving and developing within West Berkshire. Public health has an emerging role as a key partner within the integrated care system, and that, coupled with this time of public health leadership transition, gives us a real opportunity to reflect and plan for the future direction. So moving forward, the report hopefully takes a look back at that history that I've mentioned and highlights what we can learn from. The case for prevention is clearly made, and it's our ambition to reduce the burden of disease and improve life expectancy. But the report also notes that we must ensure that in supporting, in playing a part within that support system, that we don't add further to the burden of maintaining health, but build a system that builds resilience and enables people to die young as old as possible. So the concept of public health isn't new. It dates back to the Victorian era and that Sanitary Act in 1846. It then took nearly 100 years really to refine the definition of what public health is. And I think that really comes in with the breadth of what public health covers. But we see public health as both the science and the art of preventing disease, prolonging life, and promoting physical health. And this report looks at what the public health role is within West Berkshire Local Authority in doing that. Medical advances have seen the positioning and the prioritisation of public health move around the system, but back in 2013, the National Health and Social Care Policy shift saw it come back to local authority, where the remit to influence those wider determinants in the building blocks of health could really take hold. So then if we look at our public health vision for West Berkshire, the council, we're committed to improving the health and well-being of everybody in West Berkshire. And to support that vision, the public health team's commitments is summarised in the notes below. So we will take a needs and evidence-based position and promote a population level approach to the work that we do. We will take both a placed and asset-based approach to our work, and obviously continue that and strive for a reduction in health inequalities. In doing so, we need to work with partners to achieve our aims and ambitions, and we're dedicated to commissioning and delivering high-quality public health services. So where are we now? And in relation to health protection and health improvement and healthcare public health, the three different elements of public health, it's largely seen and accepted that we are healthy, wealthy, happy within West Berkshire as a whole. But we do see pockets of variation and pockets of challenge and high need, and that's demonstrated here within the health protection area. There is high vaccine coverage, for example, but actually there are some concerning low pockets of uptake. And we also see variation between different groups of our population as well. That's not unique to health protection. That goes the same for the other areas that I've previously mentioned. I also wanted to highlight some of the trends that we see in relation to sexual health, so STI, sexually transmitted infections, and HIV diagnosis. And it's just pulling out that, yes, that is demonstrating a lower incidence, but actually it's the way in which the indicators are captured that's looking at the numbers that are presenting and being diagnosed. So that may well truly indicate a lower incidence, which is a good news story, but it could also be down to poorer access or uptake, which is something that we need to understand and explore locally. And then I also wanted to highlight that there are inequalities evidence, particularly with some of the behavioural indicators and those commercial determinants of health with respect to smoking and alcohol misuse, where the rates are in line with England, but we do see these variation in inequalities. And then in respect to health improvements, just drawing out some examples from the report. Again, there is needs that are evident in relation to A&E attendance for young children and admissions for tooth decay. We see that a third of Year 6 children are overweight or obese. Now that is in line with or actually beneath national averages, but that's still a third of our children. And we also, as previously mentioned, do see a higher rate of alcohol-related and self-harm hospital admission in young people. So whilst on the whole we have good health and well-being, there are these pockets of needs that are evident. In addition, the overweight and obese prevalence in our adult population is well over half at 61%. So again, that's beneath national averages, and we score green on our RAG rating, but it's still well over half of our population who are overweight or obese and therefore at risk of further morbidity and mortality to come. We know that the highest recorded long-term conditions locally are depression, hypertension and diabetes, and therefore activity is underway to hone in and to target that. And mortality from preventable cancer, cardiovascular disease and respiratory disease, whilst lower than the national average, still saw over 100 deaths locally that would have been preventable. So our priorities moving forward. As I've mentioned, we have a continued focus to address those wider building blocks of health, including the natural and built environment in which we live, work, move and play locally. And the drive for the health in all policy approach in West Berkshire Council will continue working with partners to promote health and wellbeing at every opportunity. And that will see us tackle those health inequalities that I've just previously described. We'll continue to tackle preventable cardiovascular disease, and we're looking at additional innovative ways through community wellness outreach to look at tackling lifestyle support and health checks within communities. And of course, we commit to continuing to deliver the health and wellbeing strategy. So in conclusion, and bringing those priorities together, the report sets out the need for a balanced approach to improving public health across West Berkshire, looking at interventions that impact across the whole population, those universal interventions, but interventions that are proportionate to need. Running alongside that, there should be targeted support and programmes for groups at risk of higher need and poorer health. And then finally, looking at our secondary and tertiary preventative approaches, we need to also look at tackling established disease to prevent further ill health and deterioration and to promote independence as well. As noted time and time again throughout this report, that importance of embedding the public health approach through partnership working is absolutely key, and the commitment to the health in all policies approach in West Berkshire Council is called upon. Public Health will continue to advocate for evidence-based decisions and communications and work according to the need identified, and has set that commitment to continue to commission the high quality public health services noted within the report. And there's a nice quote to finish on. So I will pause there and stop sharing and allow the discussion.
Thank you very much, Charlotte. I mean, as I said, is that John Ashton? We can see at the bottom. Oh, hello. It's all dark. Hello, he's waving. It was a really interesting report, as I've said, and very comprehensive. And what I thought was interesting was the fact that I think John highlighted that in some ways we've sort of gone backwards as regards public health, that there's still a bit of a concentration of sort of spending on medicalised services, and that money is still being invested in large hospitals. And although we have a ring-fenced public health budget, which I think is highlighted, one question is whether there's enough money in there. And are we still, although we talk about prevention and the importance of it, are we really, putting our money into it as much as we should? And it was good to see the so much emphasis put on the importance of investing in children and young people and the first 1,000 days. But again, I question whether we've got the resources to actually deliver that. Have we got enough health visitors and school nurses and personnel there to actually give that care and provide that service? And certainly I'm hearing, and we heard in our early years presentation, which we had last meeting, that although we're doing our best, probably we do need more resources, particularly for those who are in need, for the deprived community. So are we really, is that something we need to be looking at? That we've got services, but are people really accessing them? And do we need more resources there? I don't know whether John or Charlotte wants to comment on that, or before members put forward their question.
I'm happy to chip in at this stage, Councillor, if that's appropriate. I think just picking up where you started off there, I think the paradox is that when the National Health Service was set up, it marked a big shift in emphasis away from public health and towards hospitals. And that's been an incessant trend for the last 80 years. And even most recently, since 2015, the proportion of the NHS budget that's spent on hospitals has increased, whilst that's going in general practice and community and public health has gone down. And we've got the balance wrong. And part of what needs to happen is a shift towards prevention, public health, strong primary and social care, and really hospital really as a last resort when it's really needed. And some of this is explored in the report. But for example, the trend is towards people wishing to end their lives at home, but the majority of people, the overwhelming majority of people, still die in hospital and may have a number of admissions to hospital during the last 12 months of life, when actually they may well have preferred to have been in the bosom of the family, supported by good community services. And that trend is underway, but it needs to be supported and developed. But what runs through this report as a golden thread really is the importance of strengthening self-care and community organised responses to health and sickness. And this is where the local authority plays such a key part. So in answer to your question about whether we need more resources, yes and no. I mean, we need more of the resource focused upstream to reduce the burden of ill health in the first place and to enable people to be more appropriately cared for in the community. But in the local authority, what we need to be working towards is the local authority becoming, yet again, as it was once, a public health organisation. Most of the functions of local government grew out of the public health movement of the 19th century. All those things like water supply, housing, recreation, parks and gardens, social services themselves, they all were public health measures. And in 1974, all of the system got dismantled. And this is rehearsed for the benefit of younger readers in the beginning of the report. And what we're really trying to work towards now is putting Humpty Dumpty back on the horse, but the back on the wall, but the wall has moved. And Humpty isn't the fella he was. For most public health people, and well, not most, but it's equally male and female and very diverse workforce. But it's a partnership. It's not paternalistic, as was the case with the Victorians. What we're talking about here is partnership working across the council, beyond the council, with social organisations, community groups, and so on. And that's the mission, is to really mobilise the community and support the community. So there are some very specific things that public health does, like in relation to immunisation, vaccination, screening, contraception services and so on, which are really important measures, and we need to get them right and make sure they reach the groups that are difficult to reach. But the overall challenge is much greater than that, and it's what we refer to as whole systems working. So I hope that's helpful. When you get a chance to read the final document, I hope you'll find it provides a framework for thinking not just about the work of the Public Health Directorate itself, but of the whole council.
Thank you very much for that, John. I mean, I think it's quite, I don't know, you probably weren't here for our previous discussion on health and new developments, which is task group we've just had, which is looking how we work with developers to actually think about health when we've got new buildings, new estates. And that's a lot of very relevant to what we've just been talking about, going back to the importance of green spaces. I mean, you mentioned in your report that the first council housing estate, I think, in the district, or certainly in Newbury, was St George's Avenue. And for those people that know it, certainly, even if you don't live in Newbury, the Thatcham people know it, they're absolutely beautiful houses with beautiful, enormous gardens, but really beautifully well-designed houses. It's a lovely estate. And when you compare that to the quality of the housing that we have now, it just doesn't compare. And I know land is more expensive, but it just shows how standards for what was for public housing have changed totally. And I think, and that's how important the environment is.
Well, public health grew out of the slum conditions in the 1840s that led to the pandemics of cholera, and housing and public health were so intimately bound up in those early decades. And actually, even in 1948, the Department of Health in 1948 at national level was the Department of Health and Housing. And we've actually allowed them to drift apart. The Parker-Morris standards for housing were abolished during the Thatcher years. And we have some of the smallest housing room size in Europe. My father would say there's not room to swing a cat. And when we look at the experience of the pandemic, we saw how unsuitable a lot of housing and flats were to cope with the pandemic. It was impossible to isolate somebody because the space wasn't big enough. And many flats didn't even have a landing, have a balcony to take fresh air, never mind a garden, in coping with those kind of things. And I think we have gone backwards in that respect. And I think the council approach to integrating housing with health is really important. I mean, if people are in the right kind of housing in a well-designed neighborhood, they're able to remain independent living without getting admitted to hospital or a care home for longer. And so having a strategic approach to integrating housing with health is absolutely critical as in the years ahead, as the burden of the demographic changes that are coming down the track hits us over the next 5, 10, 15 years. I think you're on mute, Councillor.
Sorry, Councillor Langford. I keep turning it on and off.
Yes.
Now Councillor Langford's here.
Yes, I'd like to hear your thoughts, please, on the sewage situation. We've talked about housing, we've talked about fresh air, all of which is good stuff. But sewage, we've got sewage. I have sewage. I sit in my garden having a nice glass of wine in the evening, watching the sewage float by. And I'd rather not have to do that.
No.
How do we deal with that, please?
Well, I'm prejudiced here. You know, I mean, public water and sewerage was built up on the rates by local authorities. And since privatisation, it's gone backwards. And I don't know, you will have, as councillors, you'll have your own political perspectives on this. But as a public health person, I think it's unacceptable that we have these private companies that have been paying their shareholders large amounts of money and not investing in the infrastructure. So, you know, it remains to, ultimately this is a political question, but it's at the very heart of public health is protection from environmental hazards of public nuisance, of sewerage in the streets. And if you, again, I think in the report, you'll find some reference to the issues in the past, which reads very uncomfortably to think that we've got some of this back again now.
Yeah, I thought it was really interesting that, you know, we're talking about this in the 19th century. And that was the origins of public health, was it? Sanitation.
It was.
Yeah,
it was.
And now we're almost at square one again. But you did refer to how the cholera epidemic basically sort of was a sort
galvanized
people. And maybe COVID is doing the same. Yeah.
That's my hope, Councillor, is that in the same way, you see, before the cholera in the 1840s and 50s in the towns and cities, the local authorities had very few functions. They issued market licenses and they protected the city boundaries against marauders and so on. But it was only the cholera that precipitated action by councils in paving the streets, putting in water and sewerage, slum improvement and so on. And that was the basis of public health. Now, what the pandemic did for us was, again, make people realize that we have to work collectively and across the whole council faced with something like that. And it's really important that, you know, 2-3 years after the pandemic, we build on the experience of the pandemic, of the work of the council working much more collectively and working in much stronger partnership with community organisations.
Yes, thank you. Councillor Jeffrey?
Thank you, Chairman. Well, you're obviously not going to be surprised, I should think, or other people in this room won't be surprised. I'm always pleased when anybody manages to get a naval allusion into anything, and swinging a cat obviously is bang in there. The
wrong kind of cat, I think.
Absolutely. The this whole business of clean water and sanitation and so on, and being the foundation of public health, and the points that you're making, that quite frankly, some of these issues are not being conducted today in the way they should be. But I know that my own particular interest, and this comes from having 4 grandchildren, is the kind of statistics that we're seeing, that I said nearly 1/3 of children are overweight or obese. And how do we manage to, particularly as a local authority, how do you actually push back against the salt, the sugar, the tobacco industry, the diving into alcohol early, all that kind of thing? How do we actually manage to fit that into the kinds of public health campaigns and so on that we can be involved in? I know that every now and again I actually will see a smoking cessation van still trucking around the area, and I'm very relieved. But my golly, it's an uphill struggle. And now,
So if I could just respond to that, Councillor, I think a lot of the discussion tends to focus on individual behaviour, and we do need to support people in healthy living, but we also need to pay attention to the conditions which shape people's behaviour. And that's what takes us into this term that's currently being used, which is about the commercial determinants. And the fact is, I mean, I would challenge you to go and try to do a week's supermarket shopping with your trolley and not get stuff in your trolley which is loaded with carbohydrates or salt or sugar. And, you know, this requires action at the government level as well as the regional and local level. I think from the local authority point of view, the questions to ask are, what can local councillors do through their own networks of political influence nationally, and what can they do locally within the council area? So one of the things that was an important part of the public health movement in the 19th century was drinking water fountains. These were provided as part of the campaign against the teetotal campaign, so that working men didn't spend their money on beer at lunchtime and on the way home from work and so on, but actually could get, you know, drink water. If you think about what the modern equivalent to that is, there were drinking fountains in the school when I first went to school. They seem to have long since gone from many schools. Having drinking water readily available means that children have a choice of not drinking sugary drinks, and councils can incorporate drinking fountains into new school developments and other places like libraries and so on. And also there's increasing interest among local authorities around the country in strengthening the use of bylaws again. The old public health used bylaws a lot, but what we're now seeing is, for example, local authorities passing bylaws to prevent fast food outlets near schools, and, you know, also using the powers that local authorities have to stop the school run dropping off kids right outside the school gates, but, you know, having safe parking areas if they're bringing them in the car at all, so that at least they walk the last couple of 100 yards in the morning and get some exercise out of it. But it's thinking laterally about how to make the healthy choices the easy choices, and what role the council can have, particularly when it comes to new developments and using what's currently Section 106 to get the developers to build in opportunities for cycling and walking as active transport and these kind of things. But I'm sure there are more conversations to be had based on the report that we're putting before the council at the moment.
Thank you for that. Is that okay, Councillor Jeffrey? Yeah. I mean, interesting you raise the issue of water, and you mentioned that in your report, you know, that we could work to have more water outlets. I mean, I remember water fountains when I was a child, and suddenly, I don't know whether it was because they thought they were sort of hygiene issues, or people, maybe they were more sort of, people started buying bottled water or thing. I'm not quite sure why they suddenly went, but if you go, I mean, I think I'm just trying to remember where I saw wonderful water fountains. I think it was somewhere in America, and people running and stopping to drink at these beautiful ornate fountains that ran along beside a park or beside a road. And we have started putting sort of little taps in walls, but people don't see them. So maybe we do need to think about something a bit more, you know, a fountain, you know, something
I can recommend a splendid new model one in Borough Market in London, which is a splendid piece of design, which is a public drinking fountain. But also, if you consider, I don't know, I'm not familiar enough with Newbury, but whether you have any ornamental fountains, because the ornamental fountains all got switched off at the same time, which seemed to be about the same time as water privatisation. So, you know, this may be something that we should be requiring the private utilities to reinstate.
We have one on the side of our town hall in Newbury, which we did look at reinstating, but we were told the piping was all wrong or something and it would cost too much, so it was too difficult. But every now and again, somebody says, why doesn't that work? You know, it's right, very accessible and it's quite nice, you know.
Well, they look wonderful, don't they, as part of the street furniture?
Yeah, so, yeah, I mean, what occurs to me again in what you're saying is, I think, again, you mentioned with COVID, that the people that suffered most from COVID were those with the morbidity, the weight, the diabetes, people who were unwell and unwell because they were in deprived communities usually. So, I mean, I think one of our big issues is where we put our resources. And although for a lot of people, it's just a case of having information about what to do for themselves, a lot of people need that extra support. And so, you know, getting that extra support where it's needed, I think, is one of our big issues, really, that we make our...
The jargon for this in public health is proportionate universalism. It's that we need to have a universal approach to things like vaccination and so on, but we need to do more for the 10 or 15% of the population who are up against it.
Right, thank you. Councillor Carter, yeah.
Hello there, thank you. Yes, thank you, Charlotte and John. I'm reasonably passionate about early diagnostics, and I'm looking at page 113, where you say evidence-based decisions in everything we do, and you actually mention using new techniques to turn data from multiple sources into intelligence, which, although you don't say AI, that to me seems to be a definition of AI. Would you agree that I'm sure you agree that early diagnostics is important, but can I also read that area as meaning to cover early diagnostics and also presumably at a community level as well? So, for example, measuring blood pressure at home potentially being used to say, excuse me, Mr. Bloggs, you need to come in, that kind of thing, or monitoring movement, or our favourite example in the world of IT, which hasn't really made it yet, is where we monitor what's going in and out of your fridge and we say, Mr. Bloggs, you're having too much sugar, that sort of thing. But yeah, I'd just be interested in your comments on early diagnostics and the use of AI in that area.
Yeah, I know. I mean, I think, you know, to just pick up on that last point, I think there's no reason why when you go to the supermarket checkout, you couldn't get a readout of how much fat, sugar, and so on you've actually just paid for, because it ought to be possible for the computers to pick up on each product that you've taken off the shelf and put in your basket, and to add up the amount of unhealthy things in your shopping basket. So, I mean, I think that's likely to come at probably starting off with, you know, the Waitroses of this world and so on. But now, what? Sorry, the first part of what you said, I've lost the track with that.
Yeah, sorry, it's probably about 3 points in one. Can I correctly read evidence-based decision in everything you do to include early diagnostics, and what kind of areas are you just briefly looking at there?
Well, in the same way that people tend to assume that screening is a good idea and that early diagnosis is a good idea, in fact, it is and it isn't, because the earlier things are, you know, brought to light, the sooner you can do something about it. But it's not an alternative to what we call primary prevention, which is stopping things happening in the first place. So if you take the story of obesity, which Charlotte was referring to there, you know, we've now got an epidemic of type 2 diabetes, and it's running at 3, 4, 5 million people in the country as a whole, and it's increasing all the time. And it's strongly related to being overweight. And it does result in enormous costs to the health service to maintain people in reasonable shape if they've got type 2 diabetes. And they're still at risk for all the things that diabetes can lead to, which includes blindness, renal failure, amputations, diabetic dementia from strokes, and so on. So the real answer is preventing people getting fat and overweight in the first place. So we have to do both. The danger of us being too enamored of the treatment option is that we don't give enough attention to the prevention option. So we have to do both.
Yeah, sorry, thank you very much. I mean, I'm guessing in other areas, I've sort of had personal experience of, I was thinking of the cancer diagnosis, which is obviously often very difficult to know that of the people that a GP sees on a daily basis, how many of them have got not cancer versus the ones that have. And of course, the cost of missing it is quite significant, isn't it? That was probably the perspective I had on that topic.
Yeah, and each of these topics that we're touching on now, we could spend a lot of time on. But you see, if you take the cancers that we know to be environmentally determined, like lung cancer to a large extent, about 90% of lung cancer seems to be smoking related, about 10% isn't, but maybe related to other things like air pollution, cyclists in traffic and that kind of thing. Then, we need to be preventing the ones that are environmentally or behaviorally determined. And if you've drawn the short straw genetically and you've got a predisposition to cancer, breast cancer in women, for example, then early detection and treatment at the moment is the best option. But it looks as though there's some very good pharmaceutical treatments coming down the track for cancers. But when it comes to, you take the example of, I mentioned type 2 diabetes. You take type 1 diabetes, which is a different disease. It's when the pancreas actually fails and we don't quite know why, and you stop producing insulin. Now, my father was a type 1 diabetic, which he developed when he was in his late 20s, and he was one of the early ones on insulin. Before that, they all died. So, they didn't cost much once they died. But once you were diagnosed and you had more or less, now he lived to be 66, but nowadays someone with type 1 diabetes might expect to have a nearly normal life expectancy. But the overall cost of maintaining somebody in decent health with type 1 diabetes over 30, 40, 50 years is a lot of money. And so we still really need to be on the search for primary prevention of that. And hopefully these are the sort of areas that there'll be advances in medical research in the future. So these questions are tricky, but what my mission is to enable the councillors and the officers to understand what's the best approach for each challenge.
Thank you very much. Great.
Thank you for that. Lots of food for thought there. Can I just quickly answer and ask, you mentioned Michael Marmot in your report, and we haven't heard much about him for a while, and he had this initiative of Marmot, not Marmite, Marmot towns. I mean, are they still around? I mean, I remember thinking it would be great if we could make our town a Marmot town. I wasn't quite sure what to do about it, but is that initiative still live?
Yes, it is. And Matt Pierce starts as your Director of Public Health on the 1st of July. I would suggest you take it up with Matt when he comes in. What Michael Marmot has done, and Michael's an old colleague of mine. We used to work together at the London School of Hygiene. Michael has really brought together the evidence for inequality in terms of the main policy areas that matter. And there are 7 or 8 of these that the Marmot towns and cities have signed up to aiming for. So you'll find they're not very different to what we've put in the report. They include things like a best start in life for children, and ensuring that people have satisfying work. Charlotte, I'm sure, would dig out and circulate the list for you. I don't know, is it in the report, Charlotte? I can't remember. The Marmot list, the Marmot 8.
I don't think the list is there. You
the
mentioned
list
Marmot.
Yeah, the
Yeah,
reference is in there, but not the list. But I can certainly forward it. And
Yeah.
just to say that most recently, Wokingham, just next door, has actually signed up to working with the Institute of Health Equity and to look to see how they can make Wokingham a Marmot area as well. So no, it's certainly live.
So you know, it's pushing at an open door if you want to pick that up from the council point of view.
Oh, that's great to hear. If Wokingham can do it, well, I'm sure we can do it.
I'm sure we can.
Got a competition here. Yeah. Well, that's given us an awful lot of food for thought. Thank you very much for sharing your vast experience with us. I mean, we are meant to, from this, trying to consider what things we might further scrutinise, but I think we might have to have a conversation about that. I mean, couple of the things that jump out that are meant were higher than national average are the children with tooth decay, sexual violence. Justin wants to say something. Yes.
Yeah, thank you, Chair. Just before we wrap up, I can't let this section of the agenda go without mentioning adolescent mental health. And I'm grateful to Councillor Jeffrey for raising the issue of children. When we talk about health, we talk about physical health, but mental health is a huge part of that too. I'm a foster carer, so I often see firsthand some of the fallout of the issues that are sort of playing out across communities. And I hate using sensationalist language, but I don't think it's an exaggeration to say that adolescent mental health is currently in crisis mode. We all know about the wait for CAMHS, for children to be seen and to get certain diagnoses. And the vast majority of schools, mainstream schools and specialist schools, the teachers and the SEND staff and the safeguarding staff that work there often do not have the tools to deal with these kind of issues effectively. So I'd be interested to know from John and Charlotte what they think, or anybody else for that matter, to hear what they think is currently working well, where we are lacking, and what we can do about that. Thank you.
Well, I think I share your analysis. I mean, after I trained as a doctor, I specialised as a psychiatrist. One of the things that led me to moving into public health was I thought that psychiatry was too little too late, and what we really needed to do was get upstream of it all. And we've seen how mental health of children and young people has deteriorated, particularly during the pandemic. I think, it's a tough world out there. It's changed a lot since we were children, and the world of social media has made it even more complicated. But at the heart of this are concepts like self-esteem and self-directedness and locus of control and sense of coherence. These are all concepts which are measurable at an individual level, or you could measure it for a school class or a school, what the quotient is for a school in terms of whether the kids have a sense of coherence or not. You probably find that those who go into independent schools have very high measures of locus of control compared with kids who are coming from more disadvantaged backgrounds. And I think it comes down to things like what I defined when I was working up in Cumbria, which was to say we need every child by the age of 18 to have a passion for something that's going to stay with them during their lives and isn't going to get them into trouble. And if you look around at what the opportunities are for children from different backgrounds in different neighborhoods and going to different schools, they're very different. And I think there are things that the local authority can do there to facilitate better opportunity, not just in the classroom, but outside it, so that some schools have lots of out-of-school activities and things like sailing clubs and climbing clubs and all this kind of stuff. And why can't they be twinned up with the schools from the more disadvantaged areas and enable those children to have the same opportunities? So this is what we call an asset-based approach. How do we map the assets of the community and mobilize them and make sure that every child has got those opportunities to feel mastery over their personal universe, because that's at the heart of this. And you will know you're one of the unsung heroes as a carer, the challenges that these young people face. And if you ask, as I did some years ago, an authority of a similar size to this, how many children leave care every year? And the answer came back as about 40 or so. And my response to that was, well, if we can't get it right to 40 children leaving care every year, we shouldn't be drawing our salary. You know, we need to join it up and have a coherent and coordinated way of enabling these youngsters to get launched into adult life. But it's about joining up all the things that we do in the council and beyond. There are lots of good people out in the community trying to do things with young people, and we need a more strategic approach to joining it up and supporting it.
Thank you.
Thank you very much for that, John. But we are looking at the services for children and adolescent mental health quite soon in this committee. We possibly should have had them here today, but this has been delayed. So obviously, Justin, I'm sure you'll have lots to say when that comes before us. So have members got any further comments or questions? Yes, Councillor Carter.
Yeah, sorry about the time. And this is probably a minor thing, but on the where are we now table, where you say about the adult health stats, page 54, 55, and this is possibly me, I can always misread something that everybody else will say is obvious. When it says 61 deaths in the under 75s from cancer is considered preventable, given what you said earlier, John, does that mean preventable meaning potentially they wouldn't have got it in the first place, or do you mean preventable deaths based on taking treatment? Because similarly, you've got the under 75s, 31 deaths from cardiovascular disease considered preventable. That one I can maybe, again, the question is that
I think it's a very,
preventable death?
I think it's a very important point you're making, and I think I'll refer it back to Charlotte to look at, but because Charlotte's been responsible for the final drafting of this, and I owe her a great debt for doing that for me. I've been doing this one, I've been doing the Reading one as well, you know. But I'm not sure whether the answer is that it's preventable if people had better access to quality medical care, or whether it means preventable full stop if they haven't smoked. So it may need some slight drafting change. And we're working here with the penultimate draft, and I'm sure there'll be other errors of drafting and omissions. And if you've got any other points to make, please feed them into Charlotte in the last day or two before we go firm on the final drafting.
Fine, thank you. That's good.
Yeah, just to come in on that point, it is based on national evidence base and modelling. And off the top of my head, I haven't got the indicator to hand, but that's an easy look, and we will certainly put clarification in to explain exactly what we mean by preventable. So thanks for raising that. And as John has said, anything else that isn't that doesn't quite read well, or there's still questions asked, please do ask them, because we can ensure that we clarify before we publish.
Thank you very much.
Thank you, John and Charlotte, for your report today and for your comments, which have been really very valuable and interesting. And thank you, members, for all your questions, which have really sort of helped to bring it to light. And John might be interested to know that the next item on our agenda is a diabetes overview. So we'll be hearing more about diabetes. So thank you very much.
I have type 2 myself, so I have a vested interest in this.
All right. Okay. Well, good luck.
That's where I drew the wrong genes in this case.
Thank you again. Thank you. I'm sure we'll be seeing you again. Thank you. Bye-bye for now. Thank you.
Bye-bye.
Right. Our next item 8, is diabetes services. And we have Kira Walker. Is this Kira Walker?
Hello, hi. Can you hear me?
Yes, we can hear you. And we have April here as well. Have we got Peter Hunt? No, yes, no.
Yep, you got me.
Okay, all right. I'll hand over to you to present your report. Thank you.
Thank you. I believe I've circulated some slides. I think they went out with the agenda, and I think somebody here is perhaps able to put them on the screen. Thank you, Vicky. Super. Okay, so well, thanks for inviting us here today to take a look at diabetes management in Berkshire West for type 2. You had a presentation from our colleague Sarah Bow and Dr. Heike Veltman about a year ago, and we're just really back to revisit you again a year later. So I believe you've all had a chance to look through the slides. So rather than go through every slide, Vicky, would you like to jump to slide 5, because the first 5 slides are more about what diabetes is and the prevalence across the country. Yeah, so if we go on to slide 5, so here it's showing you roughly how many people are diagnosed with type 2 diabetes in each PCN, which is a primary care network within West Berkshire. So just to summarise, a primary care network is a collection of GP practices, and that the combined population should be somewhere between 30 and 70,000. So this is telling you how many people within each PCN have type 2 diabetes. If you want to go on to the next slide. So this is now looking at prevalence. So this is the percentage of people that have type 2, and we can see here how it's grown over the years. So for example, A34 PCN in 1920 had a prevalence of 3.5, which was below the BOB, the Buckinghamshire, Oxfordshire and Berkshire West average, and also below the national average. That has increased steadily over the years, and we're now at 4.1, which again is still below the national and slightly below the BOB average. Okay, do you want to move on to the next slide? Thank you. So when we're looking at measurements of diabetes care and treatment, we look at 2 things. One is the 8 care processes, which are 8 processes that everyone with any type of diabetes should expect to receive from the NHS each year. There is also a 9th care process, which is the retinal screening, which is commissioned by Public Health. Once they've had their 8 care processes, we then look at how well their diabetes is managed. And that's by looking at a blood test, what's called the HbA1c. We want the measurement to be below 58. We want the blood pressure to be controlled below 140/80, and we want their cholesterol to be below 5. If you jump onto the next slide, please. So here we're showing you now the achievement of the 8 care processes. Now this is showing you it's showing you 3/4 of last year, last financial year. So this is up to December. So you can see that the 8 care processes we're doing really quite well in West Berkshire. In fact, the whole of BOB is number 4 in the whole country. So overall, we are doing quite well with the 8 care processes. Our treatment targets are slightly below the national average of 36.6. We do know there is it takes longer to improve the treatment targets because you have to wait for people to come back after starting medication to have further tests. So we do expect that to see the number picking up over the next few months or even years. Okay, next slide. Okay, so this is this is about prevention. So you heard John mention earlier that the primary prevention, and we also look at in the NHS we look at secondary prevention. So that's once you've primary prevention is to stop people getting it in the first place, but in the NHS we also look at secondary prevention, which is once you've got diabetes to stop it getting worse. So we're looking at also. So here is the primary prevention for diabetes, which we also call non-diabetic hyperglycemia. In all of West Berkshire or Berkshire West, we've had a financial incentive to practices to monitor and support people who have been identified as being at risk. So they've had a blood test that shows that they're at risk. So we've been incentivizing practices to see these people annually, carry out blood tests, give them a review and refer them to the NHS Diabetes Prevention Programme. The NDPP is a nationally commissioned service, which is a lifestyle intervention that people can access to learn about lifestyle changes, how to make lifestyle changes. We have really good uptake of that in across Bob, particularly in Berkshire West. I met with the providers this morning, and we've actually had in 1 month we had 250 referrals last month, which is well above our target. So that has been going on in Bob in West Berkshire. That is stopping at the end of this month. We are now working on a Bob-wide locally commissioned service for primary care, which brings all 3 places together into one offer. So they will still be incentivized for diabetes prevention, but it will be through other services that are offered, like the weight management enhanced service. In addition, we've got something going on. This started in July last year. It's what we call T2 Day, which is about early onset type 2 diabetes, which is a particularly strong strain of type 2 that people who develop type 2 diabetes younger, between the ages of 18 and 40, have worse outcomes, and particularly during pregnancy. Just to put things into perspective there, we used to see many more women with type 1 diabetes during pregnancy. That balance has now shifted, and it's over 50% of women with diabetes who are pregnant now have type 2. So you can see how the prevalence of type 2 diabetes is growing nationally. So we've got a program being offered out across the patch to help people with early onset type 2. We've also got this type 2 path to remission program, which you may know as the low calorie diet, which is the or shakes and soups diet, which is a 1-year intervention where the first 12 weeks of that intervention, the people are provided with soups and shakes as a complete total diet replacement for 12 weeks. That was started in Bob in September, and it's had brilliant uptake. We did a promotional event in Reading to try and get more people onto it, and it went really well. So we're having we've already used all of our places, but we've had discussions with NHS England, and they've allowed us some extra places on the programme. So that's going really well. And just to give you a few more, just some more insights on what's going on across the patch, we've got, some of you may have heard on the news about a nice technology appraisal on hybrid closed loop systems, which some people refer to as artificial pancreas. So a nice technology appraisal has been issued to say that the majority, all children and young people with type 1 diabetes, and many eligible people with adults with type 1 diabetes should have access to this technology. So this is a really big change for our trusts to start implementing this. So with NICE have given us 5 years to implement this technology appraisal, which is unusual. It's usually only 3 months, and there is some funding attached to it as well. So we're working with the trusts at the moment to get that rolled out over the next 5 years. But we're really positive. This is really good news for people with type 1 diabetes. So that's a big piece of work that we've got going on. And the next slide, please. So this just gives you a pathway of what happens when people are on the left. You can see pre-diabetes or non-diabetic hypoglycemia, what happens, and then if they have type 2, the sort of things that they can expect to receive from the NHS. And do you want to move on to the next slides? That looks like that's it.
Right, thank you. Thank you very much for that. Okay. Can I just ask a question before we go on to broader questions? In the 8, what's it called? The 8 care processes, it says creatinine eGFR. What is that?
That is a blood test, I think. GFR is the blood test. Yeah. So they have they have a blood test, or one, they go once, and have 3 things measured. It's their UNEs, which is where the GFR is. Then they have their HbA1c, which is the glucose, and they have their cholesterol. They also have a urine sample, and that's actually, is that the urine ACR? That could be, I'm going to have to go back to the slide, sorry, without seeing what's written on there. So that it could be that you're referring to. Let's see. look at my slides.
HbA1c and creatinine EGFR.
Yeah, so that's a UNE's blood test. It's a blood test. So it looks at kidneys, I believe. I'm actually a manager, I'm not a clinician. So if any clinicians on the call would like to step in and correct me here, please do.
Okay, thanks for that sort of clarification. The weight management obviously is crucial here. And you mentioned, I think, which is probably an ordinary diet, you go through patient being referred to weight management enhanced services, and then you refer to this special diet, which I assume is total diet replacement is for people with quite severe weight issues, I'm assuming. I'm just wondering how sustainable all those are, you know, because people can lose weight and then they put it all back on again, particularly if they've done something totally different, you know, and it's done quite quickly. You know, how successful, how sustainable are those? And who do you get enrolling in these programs? Is it the usual suspects who possibly would do things on their own, but, you know, don't really need a little bit of extra support? Or are you really getting the people who, you know, again, from maybe the deprived and minority communities, are they coming along too?
Yeah, so that's a really good question, and that's been a big focus of the entire programme nationally. So it is geared towards people experiencing inequalities. There is a strict referral criteria for it, and it's evidence-based. So for example, some of the criteria are that they must be under the age of 65. They can only have been diagnosed for 6 years, and they can't be on insulin because it's potentially dangerous. So there are further criteria around pregnancy and some other things, some other comorbidities, but there is strict so it's not for everybody, and we were only given 250 places per year, which we've already filled, but NHS England have allowed us to start using next year's allowance, and said that other areas aren't getting as many, so it should balance out. So we can keep going until we're told to stop.
Right, thank you very much for that. And also, page 140, you talk about the variation in achievement across different practices in Berkshire. There's quite a massive variation, 25% to 86% in achievement.
Yeah.
Meeting the targets. Do we know anything about why that is? Is it just that they haven't got the personnel, they're not bothering, or is it the practice population? Do we know anything about that?
No, you're absolutely right, and I do think that probably the single biggest inequality in diabetes, or type 2 diabetes in particular, is which GP practice you're registered at, and how skilled the people are that to look after you. So our Bob Wide LCS attempts to address that. So we are it is about education. So diabetes management isn't all part of core general medical services. So where there are gaps, we need, as an ICB, to look at our population health and try to fill those gaps. So we look at education, we look at reimbursement to practices to allow their staff time to go away and learn what they need to know. We're trying to integrate the service, so that's what we are as an integrated diabetes delivery network, so that we're integrating with secondary care and community care, so that everyone's coming together in a multidisciplinary approach to try and bring up those practices that perhaps aren't performing as well. It can be any number of reasons. A lot of the time it's workforce. So they could have a very experienced one practice could have a very experienced diabetes nurse who retires or becomes ill and unable to work. And then they have a gap that they don't have that skill set then to look after those patients until they've filled that gap. So it is, it's variation in general practice is a big challenge, and that's one that we're working very hard to address.
And you mentioned, I think somewhere in your report, that 10% of your budget is spent on diabetes services, which is great.
The NHS budget, the total NHS.
And obviously this is preventable, as we've been hearing from John Ashton.
Largely preventable, largely preventable.
Apart from the type 1. Do you think we should be instituting some bylaws, as he suggested, about fast foods and sweets?
Absolutely. I really agree with everything he said. It's some great ideas there. So yes, absolutely.
Because it's just too tempting, isn't it? And people become addicted to these foods that are doing them no good at all. Yeah. Any members got any issues to raise? It was quite an interesting report. Councillor Langford?
Yes, your inequalities with doctors, if I may turn to that. I think it's almost a self-fulfilling prophecy in some ways, because doctors are human beings and they want to live in nice places like Newbury, for example, perhaps don't want to live in less pleasant places, perhaps, dare I say, like Reading. I should be drummed out of Reading next time I go, I'm sure. So apologies to Reading. So doctors want to live in nice places. So there will be competition between doctors which practices they go for. So you will get the better doctors, dare I say, going to the nicer places, and the less good doctors going to the less nice places. So it becomes a self-fulfilling, a perpetual ring of disadvantage, really.
Maybe, yeah.
Patients. I'm just asking you, would you like to comment on that, please?
I mean, it's all about personalities, but we have some fantastic doctors in working in areas of deprivation, and they are absolutely wonderful. Some really passionate people. The variation is more to do with the education that they receive in type 2 diabetes. So postgraduates you don't come out of medical school knowing everything you need to know about type 2 to manage it in primary care. So, for example, starting insulin, if a patient needs to go onto insulin, it's quite a lengthy process. There's a lot of conversations. You have to teach the person to self-manage, and they're quite long appointments. So this isn't part of core general medical services. So if we know that the best place to do that is in general practice. It's better that they have that care closer to home and not in a hospital. But it's helping them to be educated in that and supporting the practices when they want to do it but don't feel confident or safe.
Thank you. We've got April, and is it Kate? Are you Kate over there? Did you wish to comment from the Council Public Health perspective, and on the Community Wellness Outreach Service, how that is going?
So just to repeat, so a lot of what we've heard about this afternoon in terms of things that John has spoken about, and also Charlotte's spoken about as part of the report, prevention is absolutely key in this, in terms of healthy weight and our population being really physically active, and inequalities obviously plays into this as well. So I asked Kate if she would come along this afternoon to talk to you all about one of the projects that we are running at the moment through public health and adult social care, working together to deliver a project around CVD prevention outreach. So Kate will talk about that project in a little bit more detail, but it is around delivering NHS health checks out in the population, rather than asking our population to come into the surgeries. We're taking this prevention programme actually out into our communities. But a part of that programme is that we're also giving people advice about healthy eating, about physical activity, we're signposting them to where they can get support. We've got some great interventions in West Berkshire in terms of physical activity. We've got our free walking programme. We've got fantastic Run Together programme that Sue Bennett looks after for us across West Berkshire, which is run by volunteers. We've got a wonderful exercise referral scheme that runs through our leisure centres across the district, run by Everyone Active, our leisure operator. So we've got all sorts of different things that are available for our residents, and part of the programme that Kate is looking after is about making sure that we are signposting our residents to those services so that we prevent diabetes really in the first place. But I'll hand over to Kate, who'll tell you a little bit more about the programme.
Thanks, April. I'm not sure what there is left to say, but I'll do my best. For those of you that don't know me, I'm Kate Toon, Project Manager, Integration and Quality in Adult Social Care, as April mentioned, currently leading on a public health project. So the Community Wellness Outreach Service, some of you will have been at Health and Wellbeing Board conference recently and seen me present information about it. It's got several strands, so it's looking at delivering 2,500 targeted health checks in West Berkshire over a 18-month programme. So we mobilised in January this year and it runs through until June next year. It's a Bob ICB funded pilot across Berkshire West. So we've got similar projects being run in Reading and Wokingham as well. And we do have friendly competition about who's done the most health checks to date. So it's quite good fun as well. So we've currently undertaken 439 health checks, but 227 of those are actually in our target priority groups. But we're expecting that number to increase significantly over the next few months, because what's actually happened now is the letters have gone out to eligible patients across the district to explain that they will be invited to a health check. And I think we've sent out about 4,000 communications to people to let them know they're going to be invited. So I wouldn't be surprised if we don't do more than 2,500 targeted health checks by the end of the project. Let's specifically look up a couple of headline numbers before I knew I was coming here. So in relation to diabetes, we've had 13 people out of our 439 so far that have shown high blood glucose levels, and they have all been referred to their GPs for follow-up appointments. 3 referrals have been made to the National Diabetes Prevention Programme that was mentioned in Peter's presentation. I can't remember the name of the lady that gave the presentation, apologies. What else are we doing? We are recruiting cardiovascular champions who are working in our communities. I know one of them has come from Newbury Mosque and another is at one of the Greenham centres that does work with youth offending or people that are former offenders. What else are we up to? A lot of it's lots and lots of community outreach. We've just had a fantastic week, Health and Safety Week at Viola in Padworth, working with their employees across the whole of the week, doing a lot of education around healthy eating, exercise programs, all kinds of things, showing them how much sugar is, how many cans of fizzy drink do you drink in a week, and actually showing it to them in bags of sugar. So putting it into like proper perspective, which I think some of them found quite shocking. We've had some lovely feedback from Viola from that. Goodness, I didn't bring any more numbers with me. I don't know if anyone's got any questions about the programme for me, but I'm happy to take questions.
I just wanted to comment on, Kate said that she'd received some feedback from Viola, and I'd read that feedback and it was really wonderful in terms of hearing about people saying that they wouldn't have necessarily had a health check before, which was really good because we took the health checks to that organisation, but also about how other people were supporting each other within the organisation to encourage others to come and get their health checks. So I just wanted to say well done to Kate and Solutions for Health, our provider for that programme, because it really does seem to be doing what we want it to do, to make a difference to our residents, and seeing that feedback I think was really quite powerful.
Sounds like a really interesting programme, going to where people are. And the word of mouth, of course, as you said, is really important. And so many people that just don't think about their health. And, it's just the last thing on their minds when they're living day to day. So, making it easier for them to access these checks is really vital. So that sounds like an excellent programme. How long is it running for? Is it sort of?
It's running until the end of June next year at the moment, but it's only a pilot, and presumably after we've done the evaluation, there's always scope for extension. We'll see what happens.
So if it's proving to be effective, hopefully it'll continue. Hopefully.
I think why we wanted to do this outreach programme, it was that we were finding that our health check uptake across the area wasn't as good as it should have been, and primary care obviously having lots of pressures as well on their capacity in delivering the health checks. They are still delivering health checks for us as well in addition to the outreach programme. But what we wanted to do is to use this opportunity to look at another model to see whether this would be successful. We haven't done this for quite a long time, taking health checks, and and a wider programme of health support out to our residents. So as Kate says, it is going to be properly evaluated. And then obviously we'll be able to look at the evidence and the findings to see, is that actually the best way to deliver our health checks going forward? So, and each of the areas, Kate was saying, so Reading and Wokingham are doing this as well, but we're all doing slightly different models. So, and each model will be evaluated. So it will be really good to see what we can learn from each other, and hopefully our project is super successful in West Berkshire. But yes, just to say that we will be looking at the results of this, because as John and Charlotte were saying, we try to make evidence-based decisions in public health to make sure that we are putting our finance where we know that we're going to be getting the best results for our residents.
That sounds really interesting. So we'll be hearing more about this in the future, and maybe the comparisons between how the different authorities are working. So it's a sort of partnership between yourselves and health, in a sense, isn't it? So primary care. Yeah, so that's good to be working together. That's very, any members, any questions, any comments? Well, thank you very much, both of you, for that. That's really interesting, and we look forward to hearing more. Thanks very much to both of you. And to Kira, who I think is possibly gone. I don't know. She's gone. Sorry, I didn't thank her, and she's gone.
It's okay. Hi, sorry, it's Pete here. I'm just about to leave, but she had to go to another meeting. I will pass on your thanks, so don't worry about that.
Is that Pete? Is it? Pete Hunt?
It is, yeah.
Sorry, I didn't see you, so you're a voice out there in the ether. Thank you very much, and thank you for attending, and please pass on our thanks. Okay.
I will do. Thank you. Take care. Goodbye.
Thank you, everybody, for that interesting report. Thank you. My microphone's off, sorry. So we now have item 9, integrated care board update, and we have Ellen Clark on screen, Deputy Place Director for Bob ICB. Thank you.
Okay now, please.
Sorry?
Can you hear me okay?
Yes, we can hear you, but yeah,
Okay.
best if you're close to the microphone, if you can keep close. Thank you very much.
Yeah, that's fine. Sorry, I know you were having problems earlier. So this is probably quite a brief update. This is our standard update report, which we present to each HOSC meeting. Relatively short report this time. We have highlighted information regarding the most recent ICB board meeting, and also within the report some headline figures around current performance for members' information. We've also highlighted in the report the approval of the primary care strategy for the Bob ICB. This is a piece of work that I believe we've discussed before in this meeting, and follows quite an extensive programme of engagement and working with patients and people in the wider community, supported by Health Watch and others, to really seek views around the future of primary care, which we hope are reflected in the strategy. The report highlights the link to the strategy itself, as well as to the reports from the various engagement exercises that were undertaken in connection with its development. And then finally, the report updates on the COVID-19 Spring Booster campaign, which is now well underway, running until the 30th of June this year. It highlights the groups that we are targeting, so adults aged 75 and over, those living in care homes for older adults, and immunosuppressed patients aged 6 months and over, and also some of the activities that are underway to make sure that we are able to target particular groups who might otherwise find it more difficult to access vaccination. And we've highlighted a number of the communications and other events and services that we're running to reach those groups in particular. So that was all I was going to say. Hopefully that gives a summary, and further information is provided within the report itself. Thank you.
Thank you, Helen. You mentioned on the first page that it's important that people get the support they need when they need it, and that people are continuing to find it difficult to get an appointment in general practice, as well as dentists. Do you know whether people are getting used to or accessing the sure of the exact term, the other non-GP practitioners, there is a term for them and I can't remember what it is now.
So do you mean do you mean the pharmacists, optometrists and
the pharmacy and also other practitioners are sometimes based in the surgeries, but yeah, the pharmacies is the newest, but there has been a suspicion or a reluctance possibly on some people to access other practitioners. Is that improving? Because quite often it's sufficient for them to see them. They don't need the GP, do they?
Yeah, so these themes are being picked up as part of the primary care strategy. I'm afraid I'm really conscious today that we're in the pre-election period, so I'm quite limited as to the extent to which that we're able to discuss these issues in more detail, but really happy to have a further conversation and to provide further information in due course with regard to that theme of the diversification of the primary care workforce, which I know is something we've touched on in previous meetings as well.
Oh, okay, that's difficult. Okay, thank you.
Apologies.
There was another thing I highlighted here about you said we're among the top systems in the country with uptake of vaccinations and those who are most vulnerable. Are you talking about elderly people here or young children or both? It's on your page 150.
I would want to check that if that's okay. And apologies, I didn't write this report, so I'm happy to provide some more breakdown on that point and which particular vulnerable groups are being referred to, if that's okay.
Thank you, Helen. Councillor Jeffrey has a question.
Not a question, more an observation. I absolutely believe that there is and should be such a thing as election purdah, so that information is not put out in an appropriate way. I would be a little taken aback to seriously believe that what we were just talking about would fall under election purdah. It is not worth pursuing now, but maybe at some point, once the election's out the way, maybe we can just get a little bit of clarity on issues like that for future reference.
Okay, Councillor Jeffrey, I don't think Helen can comment on that, but yes, it is a difficult issue, isn't it? Thank you. Councillor Carter?
Yes, I was going to pick up on the comment that you made, which Councillor Jeffrey picked up on, and I wasn't expecting you to raise it, so I can't remember, but the ICB did provide a response on the query of the role and the use of that additional role at the surgery, the AR, what does it stand for again, did we say?
The additional roles reimbursement scheme, yes. Which is the funding for different practitioners in primary care. Yeah.
Yes, that's right. I mean, I guess I just asked my comment, but if you can't comment, then that's fine. From memory, the response that we had on it to the probably 2 meetings ago was that those roles obviously existed. In fact, the report we saw earlier in the meeting today obviously makes clear they do. My understanding, and maybe it's wrong, is that when a patient rings the GP, they effectively say the goal is that they say they've got a problem, and the process is that potentially they're routed to one of those assistant roles rather than the GP. And the idea, I think I was told, was that when they put the phone down, their journey is in progress in some way, and that's the experience that we don't seem to see happening, and we don't. Either I misunderstand, and that's not how it's meant to work, or there's something else amiss. But I'm assured we do have, for example, that role in our local surgery. But my experience and others is you ring up to book a doctor's appointment or not, and that's it. There's no sort of triaging of you off to somebody else. So, we might say, okay, we can now go to the pharmacy maybe separately, but that's the patient deciding to do it. Do I misunderstand that use of this additional role, perhaps? Is my question.
So no, I think the additional roles are in place within primary care. The way that they're used and the exact process will vary from surgery to surgery and from practice to practice. Again, happy to have a more detailed conversation on that at a later stage, if that would be helpful in connection with the strategy. but it does vary from practice to practice in terms of the detail of the process that you're describing.
Yes, okay, thank you. Maybe that's something to consider. Yeah, it's more just understanding the yeah, as I said, the interaction with the surgery and what's the master plan, I suppose, for that to relieve the pressure on the GP, I suppose, but also solve patient issues. Yeah, that's kind of the context.
Well, that's
Yeah,
interesting
thank
because it's
you.
a different experience in my surgery. It's probably the opposite, really, I suppose. I think it's different. Yeah, when I ring up. In fact, I don't know. I don't find my surgery as accessible as it used to be, but at least they are doing that role. But I mean, these issues, and we've got Fiona coming on soon, so I mean, Health Watch can often look into these sorts of issues on behalf of. But anyway, thank you, Helen, for that. Any more questions or comments from anybody? No? Okay. Thank you very much, Helen. Thank you for your report. Thank you. Bye-bye. Right, now we've got Fiona on screen. Thank you, Fiona. Fiona, who is the Chief Lead Officer from Health Watch West Berkshire, and she's going to provide us with an update on Health Watch's current activities. And I think we have a written report here, I think, which was given to us earlier, just to give us an overview of the sort of things they've been doing. So over to you, Fiona. Thank you.
Can you hear me okay now? Can you hear me
Yes,
okay?
we can hear you. Thank
Great.
you.
Okay, thank you. It was not unmuting. Good afternoon. Hello, Chair. Thank you. So good afternoon. I'd like to give you the report for the Health Watch West Berkshire. So we've recently produced our annual work plan for 24-25. And in that, which you have a copy of, I believe, in that we will be looking at pharmacies. We attended the Health and Wellbeing Board last year. Well, we attend it all the time, but last year we had a request that we look at wait times within pharmacies in West Berkshire. So what we're going to be doing is, since then, in the advent of Pharmacy First has come out in February this year. So we are going to be looking at that, including wait times, how Pharmacy First is being integrated into the pharmacies, how the public are perceiving it, etc. So that's what we're going to be looking at. So we're going to kind of be doing a snapshot within the next couple of months, and again a little bit later, again during the year, whilst it's embedding into the service. We'll be across all of our projects that we will be doing. Health inequalities are very much to the fore of them. So we are actually setting up projects to speak to those who are underrepresented in our community. So we have a GRT, which is Gypsy Romany Traveller project, but also we are going to include boating community and the army spouses, hopefully, which has come under this as a separate issue because they are slightly different, although they do come under the heading of health inequalities, but under a slightly different branch. We're also going to be looking at maternal health, basically on the back of a couple of reports over the last few years, the Better Births and Embrace. We're just going to have a look at how the maternal journey for people who give birth in our local hospitals, what the previous reports recommended and if they have been put in place going forward, and how the journeys have been included in the 6-week checkups for people who have given birth recently over the last 2 years. Youth health, we have been speaking to public health at the local authority and had some fantastic meetings around our project that we're hoping to look at, speaking to young people about when they become 16, they are able to, they become able to sort out their own health things, you know, going to the doctor, all of that sort of thing. So a lot of the young people that we have spoken to in previous projects are not quite sure about how to do this, where they can go, where they can get the information from, what services are out there that they can you know, go to by themselves, etc. So what we were planning to do is go out and do a big kind of project out into the schools and the college sixth forms to give this information to the young people so that they're kind of preparing themselves for adulthood. And then we have another project which we're looking at is social care at home, which we will be covering unpaid carers who are currently looking after people with dementia and Alzheimer's. So primarily it's how they're accessing support for themselves, because we know that there's a lot of support out there for people with Alzheimer's and dementia, but for the carers who deal with this cohort of people, it can be incredibly stressful, very hard and very difficult time for them. And so we were kind of wanting to find out who supports them when they're going through this particular journey with their loved ones. So that's pretty much our main topics. And then we have the army spouses as again coming under the health inequalities, but we only have the one really, which is the cartography one at Hermitage, the barracks over there. So we're going to hopefully be speaking to the army spouses there just to find out what their experiences are of accessing NHS. Initially, we were told that the soldiers can have the soldiers are looked after by obviously the army, but the spouses have to come out to the external services such as RGPs, the hospitals, etc. But recently I had a discussion with somebody who said that actually that's not happening like that anymore. So we're going to do a little bit more investigation before we continue with this particular project. So yeah, it's going to be a good and very busy year for Healthwatch.
Thank you, Fiona. Anybody got any questions or comments on the report? Can I just say on the youth help, I assume youth health, you're using the Waterside, Newbury College to access young people as well as the schools?
Yes, we are, and Berkshire Youth as well. So yeah, we're going to try and reach out as much as we can to get the young people of that age where they become responsible for their own health.
Thank you. That's really important. I mean, if members have any general questions about Healthwatch, because I mean that there is an anxiety among Healthwatch employees that people don't know enough about who they are and what they're there for. So, you know, if you want more information about Healthwatch as an organisation, you're welcome to ask such questions now. I mean, members of this committee probably do know because you've seen Healthwatch before, but you know, as councillors, do make sure you spread the word among your community about the purpose of Healthwatch and how it can help with different issues in the community, you know, such as issues with your surgery. If you don't think you're getting good service, then that's something that Healthwatch can actually look into. They can do what's called enter and view, which you can do in a surgery or in a care home, lots of facilities. And you do inform the surgery that you're coming, but you do a very sort of low key, just going in and talking to patients and staff about how people perceive the service. So it's staff as well as patients, isn't it? Usually it's both sides of the coin. And that often is quite beneficial.
Yes, so we are a statutory body and we have been given these powers to be able to do that. So, and we do have to, you know, if we monitor, we constantly monitor public feedback. And so if we do hear any issues with any service that covers health, we are able to approach that service and ask maybe how things could be improved. But obviously too, we do get compliments and we do like to pass those on too from public. So yeah, an event this weekend, we had some amazing feedback, very positive about some services, which I will be feeding back shortly. So it's a really, you know, we try to hear both sides of the coin, as it were.
Thank you very much, Fiona. Thanks for your report and thanks
Thank you.
Thank you very much. Thank you.
Thank
Bye-bye.
you. Bye-bye.
Item 11, members will have the work programme in front of them. Have you got any comments on that? And just to note that children and young people's mental health and neurodiversity pathways, as well as adult mental health, were on the programme for today's meeting, but were unable to be on the agenda for various reasons, and so they will be rescheduled. So hopefully we're looking at possibly having an additional meeting just to look at those two practices because they will demand quite a lot of attention. Yes, Councillor Jeff?
Please, can we have it after the 4th of July?
Definitely. It's not going to... Yes, Councillor Lamb?
I hope I'm doing it at the right time in the agenda. I'm not quite sure. I think we've had some very good reports here today, but I think the two highlights of the meeting for me today was John Ashton and Caroline's report. And taking into mind John Ashton's message that we should do everything we possibly can to prevent problems happening in the first place, which makes a great deal of sense to me. I was wondering, given the excellence of Caroline's report, if we couldn't continue to have a group like that, perhaps chaired by Caroline, if she was well so minded, that focuses on prevention, so that it's a separate body, but it comes up with 6 or even 3 recommendations every, I don't know, year, once a year or something like that, so that we can put more focus where John said we should. Focus should be more on prevention than on the ultimate cure. So perhaps we should take that medicine from him on board and perhaps think about that. That's just a thought I'd like to
Thank
throw.
you for those comments, Jane. I mean, I think I totally agree with you. I think that was a very valuable report from John, and certainly the health and improvements was very valuable too. We do have a policy called health in all policies across the council. So I think that is something that we need to be constantly bringing to light and making sure this is happening. We have April here, who is part of the early years inequalities task group. I'm not quite sure, is that ongoing? And that, I think, is probably to some extent would be taking on some of the issues you're talking about. So there are a lot of task groups and things going on behind the scenes that we're not all necessarily aware of. If you can attend Health and Wellbeing Board, just tuning in to what they're going, you don't have to be at the meeting. You find out much more about what's going on sort of in the tasks group on Health and Wellbeing Board. And I think that would give a bigger picture about the work and the preventative work. But I certainly think we should be definitely focusing more on prevention, and whether your suggestion, I don't know, bringing it all together under one. But I think you probably, my own feeling is that there's a lot of work already going on. Does April want to comment on that?
Yes, there is, and we've got our health and wellbeing strategy that sits under the does all the work of the Health and Wellbeing Board, and the delivery plan that sits underneath that. So that's kind of where that prevention work happens. But it's really nice to hear your comments in terms of how important prevention is, because it absolutely is. If we can get our prevention right, and we know that, then that gives us healthier residents, happier residents. And obviously that's what we really want to do, is to focus on that prevention. And that's really what the work of the Health and Wellbeing Board is about through our strategy, delivering prevention activities and initiatives. Not all prevention, because some of our work is a little bit more upstream as well, but a lot of it is based around prevention.
But you're right, we need to be talking about it more. We did talk about in the end of Caroline's report about having training for members on public health, which is all about prevention, a lot of it. So I think when we have that training, I think the sort of thing you're talking about, if you have a look at what's happening on Health and Wellbeing Board and see what you think, if you still think it's not being addressed or certain issues aren't being addressed, You know, I think these are things to keep looking at. So I think you're very important that you've raised this, and it's good that we, you know, hopefully can be champions for public health and prevention across the council.
Can I just ask a supplementary then, please? What I particularly liked about Caroline's report was her 6 recommendations. They might not all see the light of day. They might not all be practical, but she came up with 6 precise recommendations that then...
It wasn't just Caroline. I think Vicky wrote the report and this came out of the working...
No, I'm sorry. I'm talking about Caroline's report. I'm not saying it was just Caroline. But I've lost my train of thought now.
I think you're saying it was very specific.
It was specific and something that somebody can go, we can take up, we're going to take it up further. And then people can do actually something about it or not, if they decide they don't need to do it. And then we can watch that progress. And so perhaps the reason I didn't realise what was going on elsewhere under the behind the curtains, I think you said, or something, but was that
working groups aren't so public.
Yes, not so public. Is that I didn't because we've got nothing concrete and specific that we can then raise up to executive and then track the progress of. That's my point.
I think it's a very important point.
Can I just so the sorts of recommendations that might come out of it is things like I don't know, having a competition or a chairman's award for coming up with 5 ways of young people in schools keeping active, or other things like that, so that we're encouraging people to look after themselves and get used to looking after themselves and into good habits, things like that. I don't know. I'm not trying to preempt it, but I'm just saying it would be something. I liked the concreteness of the report that Caroline gave us, produced by Vicky and others, I accept.
Thank you for that. Yeah, I think the subject actually lent itself to having concrete solutions. And I think we do struggle, I think, with a lot of preventative stuff about having concrete solutions. They're often quite long term, but I think you're perfectly right. And I think everybody is looking to, you know, what's your effectiveness and what are you achieving? And so having those solutions at the end actually shows people what you're planning to do and what you're achieving. So I thoroughly take your point, and I think wherever we can, we should be doing that. So thank you very much for those very useful comments, which I'm sure Vicky is sort of taken on board and we'll bear in mind. So we've got our working programme, which looks at what's happening in the future. We can add things to it, and we might, looking back at the public health report that we've had today, we might, looking back at that, think there are certain things that we want to scrutinise from that. You know, whether small issue of children's dental care, why have we got so many children, you know, higher than the national average, having to go into hospital to have their teeth pulled, you know, small issue, but, you know, why is that worse here than elsewhere? And there's lots of other subjects.
Could I just say, can we, instead of having questions, which I'm not saying we shouldn't have questions, but what I like the idea of is recommendations, not just questions.
From this committee?
From whomever is giving the report or doing the work. Recommendations means that we'll get something done. Questions means that we can not get something done.
Okay.
That's my point, I think.
All right, thank you. Okay, well, thank you for those points. And it's good that you know, please carry on, you know, bringing those things forward and making us, you know, think about things in those solution-focused ways. So thank you, everybody. So I assume no comments on the work programme, but you are free to submit any issues in future. And anybody out in the ether who might still be listening can also put things forward to the committee to actually look at in the future. So thank you very much to everybody for attending. And thank you to Vicky for scribbling away, and Gordon. And thank you, everybody, and goodbye.